infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, hey everybody, this is Robert, and welcome to Outbreak News Interviews. Now, locally acquired cases of Chagas disease are exceedingly rare in the U.S. There's only been about 28 local infections documented from 1955 to 2015, a 60-year period. Now, a recent paper in the Morbidity and Mortality Weekly Report describes the first locally transmitted Chagas disease case in the state of Missouri. So joining me to talk about this unusual case is George Turabelidze, MD, PhD. Dr. Turabelidze is with the Division of Community and Public Health with the Missouri Department of Health. Dr. Turabelidze, welcome to the show, sir.
Thank you, Robert, and thanks for inviting.
Well, let's go ahead and start out with a little overview about Chagas disease, how it's transmitted, the pathology, symptoms you may see, and a little bit about its presence in the United States.
Sure. Actually, the name of this disease in the medical literature is American trypanosomiasis, but it's mostly known as Chagas disease. And this name comes from a doctor who first described this disease more than 100 years ago. It was a Brazilian physician, Carlos Chagas. Thanks to him, this disease was named after him, and since then, millions and millions of people have been diagnosed with this condition. Interestingly, it's only prevalent in the Western Hemisphere, includes Mexico, Central America, Latin America, because that's where the vector is. So unlike the rest of the Western Hemisphere, which has millions and millions of cases, United States has much less. And before I go into that cases in the United States, I have to say that those other countries made a huge progress regarding preventing new cases, and they were nowhere close to where they were before. So there is drastically down number of new Chagas cases. Now, regarding the United States, the estimates are about 300,000 people in the United States have Chagas disease, and overwhelmingly those are people who moved to the United States from those countries, or people who spent many years living there and then came back to the United States. And as you mentioned, it is extremely rare to happen in this country, and that's why our report was remarkable, because there are only so few cases ever described. Regarding transmission, this is a vector-borne disease, and the parasite itself, its name is Trypanosoma cruzi, and this parasite is being transmitted by bugs, and their name is triatomine bugs, and they are like a blood-sucking bugs, and they get infected with this parasite from the reservoir animals, and reservoir animals are wildlife animals. But in endemic areas, even dogs and cats could be a reservoir, but mostly it's a wildlife. And so they take a blood meal from an infected wild animal, and then they go and feed on the humans. Interestingly, they like to feed on the humans at night when humans are sleeping, and that's why they bite the exposed parts of the body, like face, hands, and feet. And that's why the other name of this bug, interestingly, is kissing bug. Mm-hmm. It has nothing to do with actual kissing. It is because many bites happen on the face, around your mouth and eyes. And once they take blood meal from the human, they defecate at the same time, and the humans, even while sleeping, not realizing they got bitten because it's painless, they may wrap this poop from the insect into their skin So the parasites can go through the broken skin where the bite was, or they can enter through conjunctiva in the eye, or even through the mouth. So that's how infection happens. And then when parasite enters human body, it circulates through the rest of the body, through the blood, and settles in different organs of the human body. And unfortunately, without treatment, humans remain infected for life. So this is without treatment, this is a lifelong illness. Another feature of this condition is that once you get the acute infection, you may not have any symptoms at all and not be aware. But the fraction of cases do develop illness, and it could be like a fever and headache, some muscle aches, even could be a rash, even vomiting and diarrhea, but nothing really specific that tells you you have a Chagas disease. So this may last for a few weeks, and then it goes away without a treatment. If you do happen to see a doctor and there was a reason to run the test for Chagas disease and you are diagnosed, you can be treated and you can be cured. But because symptoms are not common, people just continue living their lives and the infection becomes chronic. And they can live the rest of their lives never knowing it, or about 30% of cases will develop complications such as the heart disease, specifically like a heart failure. They can develop some arrhythmia, even sudden cardiac death. And some develop gastrointestinal symptoms such as, for example, enlargement of your esophagus, which is the swallowing tube we have in our body, as well as enlargement of your bowel. And because of the enlargement of these organs, you cannot swallow properly, you cannot have bowel movements properly, so it could be quite a uncomfortable condition. At this point, treatment is not as effective, but it's still suggested, and some people do respond to treatment even in their chronic phase. That's regarding the clinical presentation. When it comes to diagnosis, in an acute stage, if it is suspected highly that could be Chagas disease, you can actually see parasites under the microscope in your blood. So, but it's not common. Most commonly, diagnosis happens by means of so-called serological testing, when we are looking for antibodies in the blood that we develop against this parasite. And there are different tests to find those antibodies, and based on serological antibody test, we can confirm if someone has this infection or not.
Oh, very good overview. Doctor, let's go ahead and switch gears to this Missouri case, the first local transmission in the state. Obviously it was local, so there's no travel history, but how was it discovered and what was the patient's pathology?
Yes, actually, this was a pretty normal story. Nothing you can make a Hollywood movie out of it, but it was a woman, a middle-aged woman with a kind heart who decided to donate blood. Since she was the first-time donor, everybody who donates blood for the first time gets the screening test for Chagas disease, and her test came back positive. After that, there was a confirmatory test, and it was also positive. Because of those screening tests were positive, she was seen by a physician, and a commercial test done through commercial laboratories for Chagas disease was performed, and it was also positive. At this point, the public health, us, state health department was notified, and we started investigating this case. She did not have any symptoms at the time of her examination consistent of Chagas disease, and because it's such a rare disease, very often those tests are so-called false positive, and they need a confirmation. And the best test for confirmation can be done through the Center for Disease Control laboratory. So we approached them to help us sort out this case. And we conducted more testing. There are two tests that CDC uses that they try to run in a different way, so that they approach the antigens of this organism in different ways, so we can capture one way or another if that parasite was present or not. So when they did those two tests, one came back positive and the other one was negative. So then she was had a more extensive clinical examination done, and we did find that she had a mild prolongation of her what we call PR interval, which on her electrocardiogram, which is a slight written abnormality, and you will never know unless you have a cardiography done. So that's how it was discovered with her, and she also had a mild enlargement of her heart size. So the symptoms that you would expect with such a condition. So considering these findings as well as the previous test being positive, negative, we decided to run another test, which is a definite test by CDC. It's called Ifa Test. It's kind of like a tiebreaker. When you have positive, negative tests, you do this one as almost like a tiebreaker. And that test came back positive. So at this point, we realized that even though expectation was very low that we truly have a Chagas disease in Missouri, but at this point, the evidence was pretty strong that that case was truly positive case of Chagas disease.
And this individual never left the country, never went south of Missouri, or?
Yeah, thank you. That was a part of the investigation. When we conduct investigation, public health investigation, that means extensive, long interviews with the patient about all exposures, as well as environmental investigation. When we go and actually look around where the person resides. So because of the illness, you can be infected years and years before, we needed to go quite back in her history. So we talked to her about pretty much her entire life, and we found out that she never really left the United States. She did go to Mexico, but she only went to right across the border for shopping for a few hours. She never stayed overnight and came back, which is extremely, extremely unlikely because, as I said, those bugs bite at night, right. That she got bitten then. She did travel to couple of other southern states in the United States, but she couldn't recall any bug bites or any symptoms consistent with infection. So then we did an environmental investigation. So we went and we checked all her residences within the last 20 years. And she had several of those because she sold one house, then bought a better one, and then sold that one and moved to another one. So we examined those houses for looking for actual bugs running around, which we did not find. But her husband did recognize the picture of the triatomine bug when we showed him, that he said that he had seen something like that in one of the properties. We couldn't remember which one exactly. But we did find some structures that could be where the triatomine bugs could be hiding, because they like places where wild animals could nest. So if you have a backyard with some debris or some shed, for example, old shed, and with lots of holes, the animals can get in and nest. That's where triatomine bugs come in, and they feed on animals, and then they can feed on humans. So that was our findings, and our investigation. Even though we did not find triatomine bugs in the house, still we found the conditions that could have been favorable for bugs to be present and actually bite humans. And I do have to say that triatomine bugs being found in Missouri, not once. And Missouri is one of 29 other states where we know these bugs are present. And they circulate in so-called enzootic cycle between those wild animals and the bugs, and then occasionally they can go ahead and bite a human if they have an opportunity to do that. Again, I don't want people to be overly concerned, even though this is a concerning disease. But the finding of triatomine bug by itself in the United States doesn't mean that this bug automatically is a source of parasite, because not all those vectors are infected, and even if they are infected, the transmission from the vector to human is not very efficient, which means they don't always transmit infection. So someone who finds triatomine bug in the backyard in somewhere in Alabama or Arkansas doesn't mean that they automatically have a parasite in their hands.
Okay, so the health department did their investigation. So what did you finally conclude? She contracted it via a kissing bug?
Yes, that's a good question, because the bites of insects is not the only route of how you acquire Chagas disease. It is by far the most common, but you can get it also as a baby from your mother in utero. You can get it from a blood transfusion if you are getting blood, not that you are giving blood, you are getting blood.
Right.
Or organ donation, if you got an organ from someone who donated organ and that someone was infected, and very rarely from food, extremely rare, but it can happen from contaminated food. So by far, the insect bites are the most common. And our case, she never had any blood transfusion. She never had any organ transplantation done. So, and she never traveled, as I mentioned, outside of country. So, having contaminated food would have been, wouldn't be a consideration in this case.
Yeah. Now, let me go back to the blood donor screening. And the testing of blood donors has been going on in the U.S. for at least a decade. Can you talk about how this process works? I mean, you mentioned that they test everybody for Chagas, at least on the first time, or is it just if they've been to Latin America or lived in Latin America? How does that process work?
Thank you. Yeah. The blood donor screening was introduced in 2007, and it turned out to be a pretty good idea because after first about 150,000 tests, they found that about 1 in 5,000 donors actually was infected with this parasite. So many cases have been prevented because once you are tested and you are found positive, you cannot donate blood anymore. And to answer your question, yes, every donor, the first time around, before they ever donate blood, gets a screening test for Chagas disease. So if they are found positive, they can never donate blood again, no matter what their condition is. If they have a chronic disease, they don't, doesn't matter, they cannot donate. The only ones that could donate are those that turned out to be false positive tests, which means that after initial screening test was positive, then they underwent diagnostic tests, which ruled out that person has the disease, so which means the screening test was false positive. In that case, they could be reevaluated again, and FDA has special conditions for that. When someone who was wrongly tested positive because it was false positive test, if that someone can go back and donate blood again.
Okay, well, now you write in the MMWR report, and I quote, This report underscores the importance of healthcare provider awareness of possible Chagas disease, even in the states considered low risk for this infection, like Missouri, and the need for careful consideration of the patient's history to identify possible risk for T. cruzi infection. Can you elaborate on this?
Thank you. Yes, there is a saying among physicians, rare diseases are rare. By that, we mean that, when you have someone with certain complaints, first you think about the more common diseases rather than about the rare diseases. And because there is such a knowledge from going back to medical school when students are learning about this American trypanosomiasis, that it is such a rare disease and it's not really present in the United States, that physicians do not expect and do not actively search for it. So what we mean here is to remind everybody that you have a patient who moved to the United States from endemic countries, please remember that, or someone who, even a U.S. citizen who goes on missionary trips for long trips, for months and years, or works for years and then comes back. All these people could have been at some point exposed, especially if they've been in rural areas. And just be mindful about that. And also, even like in our case, even though there is no travel history and patient lived her entire life in Missouri, when tests are positive, do not disregard them as false positive tests, but follow up and make sure that the disease is or is not present.
How's the patient doing now? Do you know?
Yes, of course. She's doing well. She had a 2-month course of treatment with a specific medication, anti-parasitic medication called benznidazole. Mm-hmm. She took it well. She had no side effects, and she continues her normal life. Great.
All right, doctor, any final thoughts on this case, on Chagas disease, or any related issue?
Yes, probably what I would say that, today we live in such an interconnected world, and any diseases can be here within days and from anywhere on the globe. And even if you don't go there or anybody brings disease here, some diseases pop up even in your neighborhood, like take Heartland virus disease, which is a tick-borne illness and was found right here in Missouri a few years ago, and it came out of nowhere. So, those conditions can happen, and the best way to handle this is to be an informed citizen. There's a lot of information on the internet, and often you can find a lot of information, but you have to be careful about what you read, and we want you to read this information, write down the questions that you have, and talk to medical professional about this. Ask them those questions, because if you go to social media, yes, you may get a good advice, but probably more likely you get a bad advice, and your anxiety and your concern only gets worse. So absorb this information, process this information correctly, talk to your medical provider. If you ask right questions, your physician will probably be as concerned as you are. They may consult specialists, infectious disease specialists or epidemiologists like me, and then together we can answer your questions. But being informed and educated is very important.
Very good. And it's a very interesting report, and I will link to the MMWR report in the show notes when I publish the podcast. And I want to thank you, Dr. George Turabelidze, for sharing your time and your expertise, sir. Thank you very much.
Thank you. It was a pleasure. Thank you.